the capillary pressure drop as it from the arterial side to the venous side. And they're just sort of showing that somewhere in the middle would actually be a point where the hydrostatic pushing fluid out would be exactly balanced by the osmotic pulling it back in. But they're just showing the closer you are to the arterial side, the greater the amount of filtration. And the closer you are to the venous side of it, the greater the amount of reabsorption. That's basically all they're trying to sort of show in this one. And this is just for an average capillary. This is for Joe average or Jane average capillary. Because I don't want you to get the impression that every capillary is exactly like this, with hydrostatic on one side and osmotic on the other side, pulling it back in. Just depends on where in your body you happen to be. Yeah. All right, now I don't think we've gotten to this slide here before. I think this should be new material. Mm-hmm. Yeah. Maintaining adequate blood pressure. Mean arterial pressure. This is basically blood pressure. Is equal to cardiac output times the total peripheral resistance. So mean arterial pressure, that's just blood pressure. The average blood pressure is going to be equal to what two things? Cardiac output and total peripheral resistance, correct? Mm-hmm. So what would happen, to blood pressure if heart rate went up? Is heart rate represented any place in this equation?
Yeah.
Can you say that again?
Cardiac output, there we go.
Because cardiac output is equal to what two things? Heart rate times stroke volume. What? Stroke volume, those two things. Heart rate, so if heart rate goes up, then cardiac output goes up, and blood pressure goes up. If stroke volume goes up, then cardiac output goes up and blood pressure goes up. So any of those things. If resistance goes up, with this increase, if you had vasoconstriction, what would that do to blood pressure? Make it go up or down? Vasoconstriction. It's going to go up. Why? Because resistance is now going up, right? So this is how it's sort of controlled. And we mentioned blood volume already before has an impact, because if you pack more blood into a certain place, pressure goes up. So the responses that we have here, starting with autoregulation. Autoregulation is a local response, and I need to sort of stress this, is that if there is ever a battle between what the central nervous system wants to happen and what the local tissue wants, the local control wins. Local control is going to override, will trump whatever the central nervous system says. So if the central nervous system tells a vessel, well, I want you to constrict, but the local control says, the local tissue says, we are low on oxygen, we have way too much waste products, we don't have enough nutrients, I need you to dilate. Which of those two is going to win? The local control, all right? So if the central nervous system or whatever says to constrict, but local says, no, we need more blood flow, we need to dilate, guess what's going to happen? It's going to dilate. That local autoregulation is going to win out here. And it's this local response that's going to primarily affect the precapillary sphincter, because remember, the precapillary sphincter is that ring of muscle that's going to be controlling blood flow through a capillary bed. Nervous system is involved in short-term regulation, doesn't control individual tissue flow, that's primarily done local, but nervous system is there to make sure that there's adequate global blood pressure to meet the demands of all the tissues that need it. Now, it's going to be regulated nervous system by sympathetic and parasympathetic. Which of these two would tend to increase blood pressure, sympathetic or parasympathetic activity?
Increase? Sympathetic.
Would increase.
Sympathetic.
Sympathetic, absolutely. Sympathetic would tend to increase it, parasympathetic would tend to decrease it. And the receptors respond to changes in blood pressure. They're actually stretch receptors. So like in the large arteries like your aorta, there are stretch receptors in the walls. And if pressure goes up, what's going to happen to the stretch? It goes up. So when they talk about these baroreceptors, the pressure receptors, keep in mind that they're stretch receptors. That's how they're monitoring that's how they're monitoring pressure. And what are they responding to? Well, changes in blood pressure, also alteration in chemical composition of blood and cerebrospinal fluid. Because I've mentioned this, I think, in one of our Zoom sessions here. If a tissue is getting low on oxygen, tissue not getting its oxygen needs met, does that tissue know why it's not getting enough oxygen?
No.
No. Could it be a respiratory problem? Could there be respiratory issues why it's not getting enough oxygen?
Yeah.
Yeah. Could it be a cardiovascular?
Could be.
Absolutely. So almost any time that a tissue is low on oxygen, all right, you're going to get a couple of responses. One is a cardiovascular response. Let's get more blood to that area, all right? So we're going to increase cardiac output, maybe try to decrease the resistance. But could there also be respiratory issues? Maybe you're not breathing enough. Could that be an issue?
Yes.
And so those two things are almost always going to go hand in hand. Anything that's going to tend to cause an increase in cardiac output also tends to have an increase in respiration. With the idea that maybe the reason I'm not getting enough oxygen is I'm not breathing hard or fast enough. So that's why we're monitoring the chemical composition. Not so much chemical composition because of pressure issues. This is more respiratory issues. And I've mentioned this before, I want to mention it again right now. You need to start thinking about carbon dioxide, a waste gas, as being an acid. Because carbon dioxide combines with water in the plasma to form an acid called carbonic acid. So if you're not already doing that, you need to start doing that today to automatically pair carbon dioxide with acid. In your brain, those two things should be equivalent. Carbon dioxide levels go up, what's happening to acid?
Goes up.
It's going up, what's happening to pH? It's going down, right? Because when you become more acidic, that means pH is going down. So if I increase my respiration rate and I get rid of carbon dioxide, what am I getting rid of?
Acid.
I'm getting rid of acid. If I slow down my respiration and I retain carbon dioxide, then I'm retaining acid. And when we get to respiration a little bit later, we'll see that it shocks most students that the main thing that triggers breathing is not low levels of oxygen. It's high levels of carbon dioxide and acid, which are the most important things that trigger breathing. Oxygen is only going to trigger it if your oxygen levels actually plummet. When oxygen levels plummet, okay, that's going to trigger you to breathe more. But when they're talking about the chemical composition of blood and cerebrospinal fluid, the primary chemicals they're looking for, carbon dioxide and acid. Now, can there be other sources of acid aside from carbonic acid?
Yes.
So if you're an Olympic downhill skier or a snowboard, just finish your event, what other kind of acid might be accumulating? Lactic acid, another type of waste product, all right? So there are several different things that can have an impact on that, all right? Now the nervous system initiates cardiovascular reflexes that affect both cardiac and vasomotor tone. Cardiac function is going to be limited to what's going in the heart. Vasomotor tone is setting the blood vessel diameter. Is this going to be done by sympathetic or parasympathetic or both? Vasomotor.
I'll say both.
Vasomotor tone. Is that going to be sympathetic, parasympathetic, or both?
Sympathetic.
Sympathetic. Oh, you dodged a bullet there, girl. Yes. Sympathetic, because blood vessels do not get parasympathetic. Blood vessels only get what, people?
Sympathetic.
Sympathetic. Now, blood vessels are always receiving a baseline level of sympathetic stimulation that sets their normal diameter. So let's say the normal diameter of a blood vessel, normal radius, normal resistance, normal pressure in it, let's say It's caused by the sympathetic sending 10 actupotentials per second. Everybody have that? 10 actupotentials per second, you have a normal diameter. For most blood vessels, if you increase sympathetic above what it normally gets, from 10 up to 15, the vessel constricts. How can you get that vessel to dilate then? If increasing it past what the normal baseline level would be would cause it to constrict. How could you get that vessel to dilate? If it's normally receiving 10 impulses per second. I'm sorry, what was that?
Lower the amount of impulses?
Lower, below baseline level. So in other words, if you decrease sympathetic withdrawal, down instead of 10, down to maybe 5 actupotentials per second, that would cause the vessel to do what? Dilate. So this is why you only need one branch of the autonomic nervous system to control a vessel diameter. Increasing sympathetic will make most vessels do what? Constrict. You can write this shit down, people, if you can't remember it. Increasing sympathetic will make blood vessels do what?
Constrict.
Most blood vessels constrict. Decreasing sympathetic will make most blood vessels do what?
Dilate.
Dilate. And again, this is why you only need one branch to cover that. Endocrine system. Endocrine system primarily controls blood pressure through long-term release of hormones that affect water and salt balance. And we'll sort of see that for a minute. It is not a rapid response, and you should know that from your 109 days. If you need a quick rapid response, are you going to use a neural response or an endocrine? If you need something that's immediate, rapid, quick, everybody should be saying, are you pretty sure about that? So, let's say you put your hand on a hot plate. What kind of response do you need in order to pull your hand away? Do you want an endocrine response or do you want a neural response?
Neural.
Why not an endocrine response?
It's not fast enough.
It's not fast enough. I'm going to be charbroiled by the time the hormones would be released, circulate, tell me to move it away here. If you need a rapid response, you're always going to rely on what system?
Neural.
Nervous system. Quick, rapid, but transient, short-lived responses. If you want a long-term, ongoing, constant effect that is not time critical right away, now you can use what system? Now you can use endocrine. And so the endocrine system is not going to be responding quickly, all right, but reinforces it, all right, by promoting primarily changes in, I mentioned, cardiac function, vasomotor term, and long-term corrective actions affecting blood volume. That's going to be the critical thing. Now, there are going to be other effects that it can have too on blood vessels. We will see that when we get to Angiotensin II in one moment. But when you think endocrine system, you should think long-term control of blood pressure. When you think short-term control of blood pressure, you think nervous system. So we take a look at control of blood pressure and flow here. Again, we mentioned autoregulation is all about these local conditions in a hard-working tissue that needs more oxygen, needs more blood flow, need more pressure to drive it there. So stress, decreased oxygen, too much carbon dioxide, increased activity are things that are going to mean that there's not enough blood flow. And that decrease in blood flow, not adequate blood flow, will trigger the local capillaries, precapillary sphincters to dilate. So we're going to flood that capillary bed with increased blood, getting back to normal pressure here. Right, arrest. When cardiac output is stable, local tissues are going to be affected by these chemical mediators one of the important things are the ones that are dilators here. And the dilators are things that are going to tend to cause an increase in blood flow to that particular tissue. That include things like an increased temperature, like when you have fever, all right? Too much carbon dioxide, decreased oxygen, decreased pH. But we're going to mention this one here, nitric oxide. That's going to be a good one to know, nitric oxide, because nitric oxide it's a gas that's released. Nitric oxide is a gas that's actually released locally. And for a long time they thought it was impossible for a gas to be used as like a neurotransmitter or hormone. They aren't. But nitrous oxide is one of the most important things that triggers blood vessels to dilate. If somebody has, for example, a patient of yours has heart palpitations or pain, let's say angina pectoralis, all right? Because maybe the heart muscle is not getting adequate blood flow, and so it's going to scream out a little bit like this. One common way that they will treat this, an oldie but a goodie, this goes back over 100 years, is with little tablets, little pills of nitroglycerin that you just put sublingually, you just let it absorb onto your tongue. Now the reason that would work, those little nitro pills, is that gets metabolized into nitrous oxide. And that nitrous oxide then is going to cause the coronary blood vessel to dilate. Hopefully that will stop your heart pains. We see this with other types of medications. All right. We're doing reproductive system towards the end of the semester, reproductive system. But you may remember, okay, from your 109 days, when you talk about the effect of nervous system and on reproductive functions. Did you talk about that at all in 109? Did you do that at all? That the events of arousal, sexual arousal, is parasympathetic mediated. Did you do this at all in 109? That arousal events are parasympathetic, where most of sort of climax kind of events are more sympathetic. And parasympathetic for this would not be from the vagus nerve, because the vagus basically stops when you get to the belly button. Vagus nerve does every parasympathetic from neck to navel, everyone here. Once you're below the navel, now it's going to be the sacral section of your spinal cord, S2, S3, and S4. Do you do this? I'm seeing deer in the headlights look, or maybe a little bit. Okay, yeah.
We did it all.
From the sacral section of your spinal cord that does the parasympathetic, basically in this area here. And they used to teach it that you would remember that because S2, S3, and S4, S2, S3, S4 keeps the penis off the floor. Because you just never forget that after that. Okay. You get S2, S3, S4. That's for they didn't teach you that one here. Well, you're lost. So the reason I'm bringing this up right now is that you can't turn on a football game now because season's over here. But while the season's on, you can't turn on a football or any kind of sporting event without seeing any kind of commercials for poor men who have erectile dysfunction. All right, just it's beer and erectile dysfunction pills. All right, but the way that they work, erectile dysfunction, is that to maintain erection, you need to have blood flow going in. That's going to cause the erection. Whether you're talking about clitoral erection or penile erection, it's the same phenomenon. You need to have blood flow going, which means the blood vessels have to do what? Dilate in order to have that. And the way that all those ED pills work is they generate, guess what compound?
Nitric oxide.
Nitrous oxide. And it's the nitrous oxide actually in them that actually causes that. Now there's a warning that goes along with that because it can cause a drop in your blood pressure. So everybody understand why that could cause a drop in your blood pressure. Because if your blood vessels are all dilating, then that means resistance is going down. If resistance goes down, that means pressure is going down. And again, these compounds cause relaxation of those precapillary sphincters, and that's going to increase the amount of fluid that's going to go through that capillary bed. Vasoconstrictors, on the other hand, are going to be decreasing blood flow to that area. And they include chemicals that are released, for example, during clotting events, like the thromboxanes and things. And these would cause constriction of them that would decrease the blood flow. So vasoconstrictors would decrease it. And again, it says here that vasoconstrictors release in response to tissue injury. Have you seen something similar to this when we talk about hemostasis, when we talk about vascular spasm? Anybody remember vascular spasm, right? Mm-hmm. When a blood vessel gets injured, its immediate response to that is going to be to what? To constrict. And these are some of the chemical mediators that are released inside of the muscle that does that. Yeah, don't worry about this. You can read this if you're interested in exercising, how it flows here. But we pick up on the part of the brain that controls it, which is the medulla oblongata. Do you remember medulla oblongata, at least from 1 and 9? Okay.
Yeah.
All right, that's a good start. So, the medulla oblongata has cardiovascular centers. Cardiovascular means heart and blood vessels. And we've already seen the cardiac centers, all right, that were the ones that would increase heart rate and decrease heart rate, correct? There was the cardioacceleratory and the cardioinhibitory. Which one of those work through the sympathetic nervous system? The cardioacceleratory or the cardioinhibitory?
Acceleratory.
That was the cardioacceleratory, that's sympathetic. The cardioinhibitory, parasympathetic. Through what nerve? Vagus nerve, because vagus is everything from neck to navel, from down here. So we have our our cardiac centers, but the control of blood vessels, do we need a sympathetic and parasympathetic to control, vascular tone, or just one? Just one. So the one center that we have here about controlling the vasomotor center. Vasomotor center, is that going to be work through the sympathetic or the parasympathetic nervous system?
Sympathetic.
If this shows up on like a test or something like that.
Sympathetic.
Sympathetic adrenergic neurons. Adrenergic because they're releasing norepi. All right. Same thing is basically noradrenaline here. And this activating these adrenergic neurons, sympathetic stimulation. This is showing the heart. But this is sort of showing the blood vessels here for sympathetic and would again cause them to tend to constrict, especially skin and visceral organs, because the skin acts as like a reserve for extra blood. We've already seen that like 2/3 of your blood is in your veins, but your skin, especially in your dermis, acts as a big reserve. Almost every tissue regulates its blood flow to meet metabolic demand. Almost every tissue has that close link between their metabolic need and the blood flow. There's only a couple of exceptions to that rule. One of the exceptions to that rule was blood flow to the skin, to the integument. Not there to actually regulate because of its metabolic need. Blood flow to the skin is almost exclusively done to regulate body temperature. That's why you shunt blood, either shunt blood to the skin or away from it, is to adjust body temperature. Because your body does not like to thermoregulate. Normally you would think about the following. If you're overheated, what do you think your body does? Your initial response. You're overheated, you're too hot, what's your body going to do?
Start sweat.
You're going to do what?
Sweat.
Or if you're too cold, you're going to start to do what? Shiver. Those two responses are not your body's go-to responses. It doesn't want to have to do either of those things. Why wouldn't it want to? Why wouldn't your body want you to sweat if it could avoid it? If your body could avoid having you sweat, why is it? Why would it?
Because you're losing water.
Yeah.
Because you're what?
Losing water.
Because you're losing water. You run the risk of dehydrating. So that's why your body doesn't want you to sweat. That's a last resort. It also doesn't want you to have to shiver because that's your body's wasting energy. So those are last resorts. The first resort, if you will, a go-to response, is to make small modifications to blood flow to the skin. So as I start to become too warm, all right, the center of my hypothalamus is going to begin by shunting more hot blood towards the surface of my skin so I can dissipate that heat. And because I'm already kind of pigmentally challenged, my skin is going to look a little bit more flush. I'm going to look a little more erythemic, a little bit more red, rosy cheeks because of that. If I am too cold, because I walked out today thinking it was going to be 60 degrees like it was just 3 freaking days ago, but no, not 60 degrees anymore, is it? No, all right? Not that I'm bitter at Mother Nature for throwing this at me, but, yeah, bitter. So I'm too cold. What's my response going to be? I don't want to shiver. My body's first going to do what to blood to the skin? Increase it or decrease it?
Increase it.
Decrease it. Because I want to keep that hot blood away from the surface. I want to keep that hot blood away from the surface so I don't lose even more heat. All right? And so it's going to send signals to my blood vessels to do what? Make them contract, especially in the skin. And I'm going to tend to look what?
Pale.
Even more pale, all right? Because of that sort of phenomena there. So those are your go-to responses. It's only if those are not adequate that then your body will go to sweating or shivering. Right? Doesn't want to have to do this. Those are last resorts. But getting back to what we're sort of talking about here, your skin is a big reserve for blood, all right? Because we don't need it for metabolic activity. We just shunt it there, either deep or superficial, based on your need to either lose heat or gain heat. So you have a big reservoir, basically, of blood in the skin that's just waiting there to determine where you want the blood to go. And so to mobilize that reserve is going to help to get your blood pressure back up. So we talk about adrenergic and squeezing your blood vessels, especially the skin, that can start to mobilize those venous reserves, especially in the skin there. All right. Notice that in this little diagram for parasympathetic, no, they're not showing anything, little negative sign there, because blood vessels don't get parasympathetic, do they? Now the reflexes that do this. How is your central nervous system able to know what's going on? Baroreceptors. Now the prefix baro refers to pressure. Like a barometer is an instrument that measures pressure. So baroreceptors are these pressure monitors, and as I mentioned before, they're really stretch receptors that are found in the walls of your biggest arteries, in the walls of the aorta, all right, and the excuse me, and the carotid arteries. They have these little bodies and then these sinuses here that when there's an increase in pressure, an increase in stretch is going to make them fire more often. And if there's an increase in pressure, think about this, increase in pressure, because maybe somebody ties a tourniquet or something around my arm or something like that, pressure's going up because resistance is going up, pressure's going up, too much above baseline levels. How can I get my pressure back down? What will the vasomotors do? How to get my pressure back down?
Dilate.
What will it do to blood vessels?
Dilate.
Dilate them. What will it do to the heart? Pressure's too high. What do you want to happen to your heart? Do you want your heart to beat even faster, or you want it to slow down? You want to slow it down. So would that be a sympathetic or a parasympathetic?
Parasympathetic.
Parasympathetic. And so that's what when they talk about this high pressure would stimulate the cardio inhibitory center. That would decrease heart rate and decrease cardiac output via the parasympathetic nervous system. It would inhibit the vasomotor tone, so instead of those 10 axpotentials per second, you're going to have only 5 sympathetic withdrawal, and hopefully those things should hopefully bring your pressure back to normal levels. Now, clinically, what you're probably going to be more interested in, more important to know is what happens if there's a decrease in blood pressure. Because hypertension, long-term blood pressure, high blood pressure, is a silent killer. And hopefully you will know this by the time we finish this class here today, that it is the silent killer, especially endemic in African American populations. I don't think I need to tell anybody this. It's kind of like mansplaining, isn't it? If I'm telling, let me tell my African American students about what happens in your population, yes. So that's so wrong, isn't it? For so many reasons, yeah. But where was I going with this?
Blood
I
pressure.
lost my train of thought.
Hypertension.
Right. So hypertension, a long-term issue, but it's not going to generally kill you right away here. But if your blood pressure drops because you have lost a lot of blood, or that you are having anaphylactic shock, all right, because you've eaten a strawberry that you're allergic to or got stung by a bee, all right, and your blood pressure is dropping really quickly, you do not have long for this world if we can't get your blood pressure back up. So in terms of short-term issues, what's more critical for your patient population, high blood pressure or low blood pressure? Low blood pressure is going to be more of a critical, immediate issue that if their body can't get it back up to normal, then you're going to have to find some way clinically to get their blood pressure back up. To get fluids into them, for example, you're going to get, maybe a ringer solution in them, or you're going to get lactated ringers. But if you're decreasing blood pressure, for example, you are beginning to bleed out, all right? Internal bleeding will do the same, all right? Then that low blood pressure, there's going to be decrease in the baroreceptor, less stretch, and that's going to stimulate the cardioacceleratory center, all right, to increase heart rate, correct?
Yes.
To increase the heart rate and to try to get cardiac output up. So if somebody comes into if you're doing triage in your emergency room, that's you're the nurse, you're the doctor, and you're doing triage, and somebody comes in and it looks like they've lost a lot of blood, or maybe they don't even look that way, but they look very pale. You can't see a lot of bleeding. Could there be internal bleeding that you don't know about? Mm-hmm. All right. If that person has low blood pressure, what would you expect their heart rate to be? Normal, higher than normal, or lower than normal?
Higher than normal.
Higher than normal, because their body is trying to get their pressure back up. Their body is trying to get their pressure back up to normal levels. That's negative feedback, right? Something drops, you're going to try to promote back up. So that patient is going to have a rapid heart rate, but the pulse pressure is going to be very weak. It's going to be very rapid but very weak. It's not going to be a bounding pulse like when you're doing aerobics. Stimulate the vasomotor center, so you get vasoconstriction, which is another reason that if my blood pressure dropped, I might look pale, because my body's trying to get my blood pressure back up by making my blood vessels do what? Constrict. And especially when you constrict the ones in the skin where you have this big reserve, it's going to tend to make you look more pale if you are, as I said, if you're sort of pigmentally challenged. Now notice that we also have chemoreceptors in the same vicinity where we find the baroreceptors. Not exactly the same, they're adjacent to the places where we have them, but what are called the aortic and carotid bodies, which are right near those sinuses, just adjacent to them, that are monitoring blood gases and blood pH. Because we mentioned before, your body doesn't know why there's not getting enough oxygen to the tissues. It could be a cardiovascular, it could be a respiratory. So, to be on the safe side, all right, anything that would cause a decrease in pH, meaning we're too acidic, all right, increase in carbon dioxide, all right, or a decrease in oxygen, all right, is going to stimulate both the cardioacceleratory and the vasomotor center to try to get your cardiac output up, because your body doesn't know. Maybe it's because you're not getting enough air into your lungs. So anytime that there's a decrease in this, all right, that would normally cause an increase in respiration, you're also going to cause an increase in cardioacceleratory vasomotors to do that. All right. Medulla oblongata, again, is where we are monitoring all this effect here. And again, the biggest thing that's going to have an impact on it is carbon dioxide and the acid that goes along with that. Far and away the biggest thing would trigger increase in cardiac output, increased respiration. And this is just sort of showing how this all sort of fits together. Something, homeostasis is disturbed. Too much carbon dioxide, decreased pH. Are those things almost always going to go hand in hand? Elevated CO2s and decreased pH? Are they pretty much generally going to go hand in hand?
Yes.
Yeah. Because more carbon dioxide means more carbonic acid, and that means pH goes down. So if this has a lot of this, well, would this tissue need more blood flow or less blood flow? That's got low carbon dioxide, or it's got high carbon dioxide, sorry. High carbon dioxide and too acidic, low oxygen. Would this tissue want more blood or less?
More.
Are we're going to try to get pressure up or down
Up.
to get that. So these things are going to stimulate the chemoreceptors, stimulate the respiratory center, so you're also going to be breathing faster, we'll see that. But what we're focusing on here is that the cardioacceleratory center would be centered to speed up your heart rate. All right, vasomotor centers, so we get vasoconstriction, and hopefully those things will bring your blood flow, the pressure back to where it should be to meet the needs of that tissue. All right, endocrine. Now these two hormones that are mentioned here, epi and norepi, are about the only ones that tend to be very rapid acting. And you covered these in 109. These are released from the adrenal medulla. It's an extension of your sympathetic nervous system, an extension of your fight or flight response. So in fight or flight mode, all right, when you're running from the monster, that increase in adrenaline release, the epi and norepi here, is going to tend to cause a short-term increase in heart rate, increase in blood pressure. Hopefully help you get away from the monster. Other hormones we will focus on in a minute here, because these hormones, ADH and aldosterone, primarily are going to have an impact on your kidneys, ability to retain water and salt. Erythropoietin, you know, is a hormone that triggers red blood cell production. Again, if you're producing way too many red blood cells, then you're going to have a high resistance. Not as big an issue here. We are going to be focusing on this middle one here in a second here about angiotensin II, and we'll get to that. Don't worry about the other ones as much here. Let's see how this one works here. Antidiuretic hormone, ADH. ADH is a hormone that's whose primary function, let's do this. The primary function of ADH is to maintain osmolarity, not blood pressure. Its primary role is to do what? Maintain osmolarity, the right concentration of bodily salts. And normal osmolarity should be roughly around 300 millismolar. That's an isotonic solution. Remember isotonic? Remember hypertonic, hypotonic? Remember all those tonics? Slightly less than 300, it's probably closer to 290, but we round up to 300. And it's really the job of ADH to try to maintain this level. Because what this hormone does, and we'll see this again when we do the kidney, is that this hormone pulls pure water out of the forming urine and returns it back to your body. That's what this hormone does. What does it do? It pulls pure water out of the forming urine and returns it to your body. So if ADH levels are high and you're pulling pure water out of your urine, returning it to your body, would you be producing a high volume of urine or a low volume? Would you be low volume? And what would the concentration of the urine be like? Would it be very concentrated or very dilute? very concentrated. So this is a hormone that would be released, for example, when you're dehydrated. If you're dehydrated, you're going to release more ADH, so you conserve what? More water. If I'm overhydrated, like something, oh, it's good to drink like 6 glasses of water a day, so you drink all 6 glasses like in one sitting. Maybe not the smartest thing to do. But if I drink all this pure water, what's happening to my osmolarity? It's decreasing, right? Because I'm diluting my tissues, all right? And by doing that, I'm going to stop secreting ADH. And without that ADH, I'm going to, instead of conserving water, I'm going to be, right. So I drank all this glass, so without ADH, I'm going to create what, a high volume or low volume of urine? And what will its concentration be like? It'll be very dilute, it'll be very clear, not have much odor. So I drank my 6 glasses of water, and by shutting off the ADH, I will now basically pee out 6 glasses of water. It won't be pure water, but it's going to be as close as your body can sort of manufacture. But anytime that you're affecting water that you're retaining or eliminating, would that have an impact on blood pressure? Yes.
Yes.
So even though antidiuretic hormone does not initially have a huge impact on blood pressure, it's there again to what? Maintain osmolarity. It can't help but have an impact on blood pressure as well. So its secondary effect is primarily its effect on blood pressure of ADH here. So when you become these osmoreceptors are one that respond to changes in osmolarity, and the hypothalamus are the ones that are releasing this. And ADH allows you to conserve water. If I conserve water, I'm decreasing urine volume, my total body water increases, and then if my total body water increases, then my blood pressure should be also increasing too. But again, this is a side job of ADH. It's not the major thing that controls blood pressure. It's a side job here. Now we're getting to the big one here. Aldosterone. Aldosterone is the most important hormone for controlling blood pressure. That's its job. It's released primarily in response to changes in blood pressure. Primarily. Because unlike ADH that just pulled pure water out of the forming urine, aldosterone pulls salt and water out of the forming urine. So because it's pulling salt and water, it doesn't have, aldosterone doesn't have a huge impact on the concentration, on the osmolarity of what's left behind. It's mostly just having an impact on how much salt and water you retain. Is that going to have an impact on your blood pressure? Massively. Now, aldosterone does that, follow me, but by affecting how much sodium your body retains. If I retain sodium, I'm also retaining water, right? And my blood pressure should do what? Go up. If I eliminate sodium and eliminate water, then my blood pressure should go down. But there's another ion that cannot help but be involved in this, because there's another ion that is linked to sodium by some little pumpy thingy. The sodium potassium pump, which means anytime that sodium is going to the right, potassium is going to the left. Anytime sodium would be going up, potassium would be going down. Anytime sodium is heading east, potassium is heading west. They're always going in opposite directions, meaning anytime I'm retaining sodium, I'm going to be losing what? Potassium. So that's why you're also seeing up here about aldosterone, all right, that it conserves sodium, all right, but secretion, elimination of potassium. Now, low levels of potassium can be very dangerous. They can put you into cardiac arrest. I hate when that happens. And this is a problem with a class of diuretics that people would take that would make them eliminate water by eliminating more salt. But the problem with doing that is that they're going to tend to do what with potassium, have an impact on potassium. Now the problem is we'll see the kidneys later. If I retain potassium too early in the kidneys, later on I exchange that potassium for more sodium because they're always going in opposite directions. And so there are better diuretics that we all might be heard of that'll be like potassium sparing that would have an impact on that. And we'll see that later when we get to the kidney. We're still many chapters away from getting to renal function. But since all these systems are interrelated, you're getting a little bit as we go along here. So the big thing about aldosterone, its main job is to try to maintain blood pressure by retaining salt, sodium, but in the process, you're going to be eliminating some potassium. The EPO, not going to talk about this because it has, for normal people, a relatively marginal effect. The big thing about EPO that you better know is that it's the hormone that triggers red blood cell production, released from the kidney when the kidneys are not getting enough oxygen. That's the big thing about EPO. Okay.
Can you say that one more time?
I have no idea what I said.
EPO is released when the kidney's not getting enough oxygen.
Okay.
Yeah, what she said. Right, the EPO would be released when the kidneys are not getting enough oxygen. Because that's where the sensors are, inside the kidney. They can't tell what's going on in any other kind of part of the body. Just what's going on now. And they're the ones that release it. And now we're going to get to one of the most horrible things that we're going to come across this semester. It is horrible. Not only is it horrible, but it's also awful. And tricky. But it's got so much clinical relevance that we have to cover this in some detail here. So let's talk about this here. This is the most, what they call the renin-angiotensin here, is the most important mechanism for long-term control of blood pressure. That's what we focus on. This is what's the primary thing that's controlling your blood pressure right now, as you speak.
Control the blood pressure?
Mm-hmm. Jackie, what's controlling your blood pressure right now?
So renin, angiotensin system.
Thank you. That's all I wanted to know. And here's how this works. All right? There is an inactive blood protein called Angiotensinogen. Have we seen that ogen ending already?
We saw in the first chapter.
We saw in our first chapter, right? We saw that ogen ending because we saw that with fibrinogen, correct?
Yeah.
That ogen ending tells you that it's an inactive compound. Anytime you see something that ends with OGEN, it tells you it's the inactive form of really the term that comes before it. So Angiotensinogen would be the inactive form of what? Angiotensin. So Angiotensinogen is a blood protein. Would that probably be made by the liver, like almost all your blood proteins? Yes. So there is an enzyme that's released from your kidneys, back to the kidneys, called renin. Now, renin is an unusually named enzyme because most enzymes that you come across have an ASE ending, don't they? Most enzymes, like the enzyme that breaks down the sugar lactose in your intestines, is called lactase. The one that would digest sucrose would be called sucrase. The enzyme that would hydrolyze maltose would be called maltase. Most enzymes have an ASE ending, makes them easy to pick it out of a crowd. Oh, that's an enzyme. See that ASE ending, you know it's an enzyme. So renin is an enzyme, even though it does not have an ASE ending. And renin is an enzyme that's going to be released from your kidney in response to low pressure. The lower your blood pressure, the more renin you release. So what triggers you to release more renin?
Low pressure.
Low blood pressure. What would then trigger you to release less renin?
High pressure.
High blood pressure. You've got that figured out. So if your pressure is, like we mentioned, low, you're going to start to release more of what enzyme? Renin. And now renin is going to do its job as an enzyme. It's going to catalyze a chemical reaction. It's going to convert Angiotensinogen into Angiotensin I, which is a bit of a dud. Angiotensin I doesn't really have a huge impact on your body, but there is another enzyme, go figure, that will convert it into something useful, Angiotensin II. Angiotensin II, is our star player. Angiotensin II is a star. And it will be converted by an unregulated enzyme that's just called angiotensin converting enzyme that's found in cells that line the lungs, kidney. It's a relatively common enzyme. It's unregulated. So follow me with this. See how we're doing so far. Low pressure, like if I've hemorrhaged, I've lost a lot of blood, my pressure is low. Renin release is going to do what? Go up. If renin release goes up, what's going to happen to levels of angiotensin I? Angiotensin I levels are going to go up. Then angiotensin II levels are going to go up. Everybody understand why that would be? Now, angiotensin II, I said, is the star. A star player because it has a plethora of effects. I just wanted to use that word plethora outside of the SATs. Because, first of all, angiotensin II is a powerful vasoconstrictor. Angiotensin II, powerful vasoconstrictor. And its effect on vasoconstriction is almost nerve-like in that its onset is rapid and transient, which means almost the moment that angiotensin II levels go up, your blood vessels begin to do what? Constrict. The moment angiotensin II levels would fall, they're going to go back to their normal. They would dilate back to their normal diameter. Now, what do we say the initial problem was? Somebody was bleeding out, hemorrhaging, their pressure was what? Low. What did that low do to renin? Renin release did what? Went up. That caused an increase in angiotensin I, caused an increase in angiotensin II. Angiotensin II is going to cause vasoconstriction. What will that do to your blood pressure? If I constrict my blood vessels?
An increase. Yes.
Does everybody agree?
Yes.
Anybody? Do I need to put somebody's head like in a vice and squeeze it so you can determine what's going to happen to pressure if I squeeze it a little bit more? Yeah, vasoconstriction, and that should bring pressure up. What was the initial problem?
Low pressure.
My pressure was down because of hemorrhage. My response is to cause vasoconstriction, which should bring my pressure back up. Is this an example of negative feedback?
Yes.
Absolutely. This is a classic example of negative feedback. So that's one thing that angiotensin II does on a short-term basis. Long-term, it's the main thing that triggers aldosterone. This is the most important thing that triggers the release of aldosterone, is this renin-angiotensin system. And so if I've lost a lot of blood, I've hemorrhaged, my pressure is low, and I release more aldosterone, well, aldosterone is going to help me to do what? Conserve salt and water to help to keep my blood pressure from dropping even lower. Now, what if the reverse were true? What if I drank like, let's say I drank like 5 glasses of of concentrated like Gatorade, or 6 glasses. I'm trying to give you an example where I'm drinking something that's pretty much isotonic. You with me? Drinking something, why did I say I wanted to drink something that's isotonic? Well, if I'm drinking a bunch of things that are isotonic, all right, 300 millosmolar, basically, right? All right, what's happening to my blood volume?
Increasing.
Increasing. What's happening to my blood pressure? Increasing. But is there any change in my body's osmolarity? Would that have an impact on ADH release then? No. So ADH isn't going to be able to help me, but will that increase in blood pressure have an impact on renin release?
Yes.
Renin then would go down. Angiotensin 1 levels go down. Angiotensin 2 goes down. Vasoconstriction goes down. So that's going to help to bring my pressure down by itself. But also that's going to stop me releasing, I'm not going to release aldosterone. If I'm not releasing aldosterone, well, am I going to retain salt and water? Or am I going to eliminate salt and water? I'm going to eliminate that salt and water. So I drank those 6 glasses of isotonics in a salty water. And in response to this system, the low levels of aldosterone will trigger me to pee out 6 glasses of salty water. Everybody okay with how that works? I want you to understand the differences between the way that ADH works versus aldosterone. Because they both will have an impact on blood pressure if you retain salt and water or anything, it's going to go up. But this is the aldosterone through the renin angiotensin, the most important way that you control blood pressure. All right. All right. If somebody has, let's say, somebody has high blood pressure, hypertension, we've already mentioned this before. Somebody has hypertension, there's a reason they call hypertension the silent killer, because you can feel just fine with having a high blood pressure of 160 over 100 or 200 over whatever like this, and it's doing internal damage. You need to bring, if that patient can't get their blood pressure down by diet, exercise issues, you might need some pharmacological intervention. And one very important group of drugs are called ACE inhibitors. ACE inhibitors are a little bit old school. How would ACE inhibitors bring your blood pressure down? Can somebody help explain? Why would taking an ACE inhibitor help to get your blood pressure down? Well, if I've got my pressure's up, that means angiotensinogen is being converted by renin to what? Angiotensin 1, all right? But if I'm blocking angiotensin converting renin, if I'm taking an ACE inhibitor, what will happen to levels of angiotensin 2? They're going to go down. That angiotensin 2, do I have vasoconstriction? Or would it be dilating? Dilating. Is that going to bring my pressure down?
Yes.
Without angiotensin 2, I won't be releasing aldosterone, and I'll also be eliminating salt and water. So ACE inhibitors are an important group of drugs. There are even newer ones that block the receptors for angiotensin 2. So the newest group that even have fewer side effects are the ones that block angiotensin 2 receptors. They even bypass the whole angiotensin enzyme here. All right. I'm just going to mention this quickly because this is more of an academic oddity. That when we talk about control of blood pressure, most of the ones that we're familiar with are things that are going to try to retain salt and water, retain blood pressure. There's only one hormone that we know that will bring water levels and salt levels down, and this is this one called atrial natriuretic peptide, A&P. Is the only hormone that actually works in opposition of the other hormones to bring blood pressure down. I say it's more of an academic exercise because right now, as far as I know, there are no drugs that they use for people that have blood pressure issues that just affect this hormone. If there was clinical relevance, I would spend a lot more time on it, but since there isn't, why bother? That's the way I kind of look at it. So are there clinical relevances to the hormones like angiotensin 2? Yes, a lot of clinical relevance. But atrial natriuretic peptide here is released when the atria are filled with a lot of extra blood here. And they just generally oppose what angiotensin II does. Remember, angiotensin II brings pressure up, atrial natriuretic peptide to bring it down. All right. Now, all we have left now is summary charts. We've really actually finished all the new material that we're doing. These last couple of slides here are summary changes just to try to show you how everything is interrelated to each other, which is one of the more challenging things because there's so much interrelationship between things. What happens to blood pressure when this happens to your heart rate, to these hormones? And so these are good to understand as ways to encapsulate the basics that we're talking about. Mechanisms that are affecting peripheral resistance. Peripheral resistance. What type of blood vessels are going to be most affected by these? Would they be the large arteries, the arterioles, the veins, venules? Arterioles! What? Arterioles. Because they have the greatest effect on resistance anyways. Right? Arterioles, write that shit down if you don't know that, because that's where all these chemicals and sympathetic stimulation are going to have their greatest impact on your blood pressure, is by their effect on the arterioles. So things that would increase it, epi and norepi. Do you understand why that would have an impact on causing vasoconstriction, increasing peripheral resistance? Does that does it make sense? Or is that, I'm seeing a little deer in the headlights or no?
Yeah.
A little bit of deer in the headlights. All right. What do epi and norepi, what effect do they have on blood vessels?
Constricts.
When would they be released? When would you release those hormones?
Adrenaline. Oh, fight or flight.
Okay, right. So, when you are in fight or flight mode, what's happened to your heart rate?
It goes up.
Goes up. What's happened to your blood pressure?
Goes up.
Going up. How is it getting your blood pressure up? What is it doing?
You're fucking
Constricting.
That's one way of putting it. If you're really scared and you're like me, you're kind of pale anyways. I'm going to look even more pale, right? And so that's why the expression like what happened to you? You look white as a ghost. Have you heard that?
Yes.
It's a white people expression, people. So the reason that you do that, look white as a ghost. Why would you look that way when you're scared? Because when you're scared, you're releasing what? Epi, and to a smaller degree, norepi, and they're making your blood vessels do what? Constrict. And as you constrict them, peripheral resistance is going up. All right. Angiotensin II. That was one I just mentioned a slide ago, is a direct effect, causes vasoconstriction. Would this be released primarily in response to the renin-angiotensin system?
Yes.
Yeah, which is why they have renin secretion right under it here. Because are these two things going to be linked together, renin secretion and angiotensin II?
Yes.
Yes. Neural, increased sympathetic activity, does that make some sense? Because they're releasing norepi directly onto vascular smooth muscle here. Endocrine, well, decreased renin secretion would tend to cause them. And the neural one, well, it says here increased parasympathetic, but do we really have parasympathetic stimulation of blood vessels? No. All we're going to do is really have sympathetic withdrawal. That should be on the next slide. It's not here. Okay. Mechanisms affecting cardiac output. Let's see how we do with this one. What kind of things could increase cardiac output, make your heart beat faster and more forcefully? Well, some of the same players that we've seen before, epi and norepi, do that. Thyroid hormone, we talked about a little bit earlier. Thyroid hormone also tends to cause an increase in heart rate and blood pressure, which means that if you have a patient that has hyperthyroidism, because remember the thyroid hormones, T3, T4, triiodo, you wipe that slate clean right after 109, right, to make room for new material. Right, but the thyroid hormones are those that speed up your metabolism. Speed up the ATP pumps, or utilization here. And so they are the ones that would tend to cause you to have a faster heart rate if you've got hyperthyroidism. If you're hyperthyroid and you're burning too much, are you going to tend to feel hot or are you going to feel cold? You're going to feel hot, right? So people that have hyperthyroidism often feel very warm. Oh, it's always hot in here. As opposed to people who have hypothyroidism, they're going to feel cold. But hyperthyroidism, they're going to probably have a rapid pulse and their blood pressure is probably going to be high. Is that a problem with people who have hyperthyroidism? Yeah. Neuro, we've already mentioned for the heart, increased sympathetic, decreased parasympathetic, and that functions well because the heart does get sympathetic and parasympathetic. Endocrine, atrial natriuretic peptide, again, that works in opposition to angiotensin II. Little impact on it to decrease heart rate, but it's again more of an academic exercise. The other two are really important ones. That increasing parasympathetic activity of the heart and decreasing sympathetic will both slow it down. Let's talk about things that would have an impact on blood volume. If blood volume goes up, blood pressure does what? Goes up. So what kind of mechanism would affect? Are there hormonal things? Yes. Angiotensin II. Yes. Because of angiotensins II effect on what hormone? Oh God, I'll do it all myself. Aldosterone. It's all about aldosterone for that, right? ADH. Remember, ADH is primarily going to be released in response to changes in osmolarity. But anytime you're retaining water, for whatever reason, your pressure is going to go. Let's try that again.
Sorry.
Anytime I'm retaining water, my blood pressure is going to do what? Go up. And again, it all deals with, ultimately, will these hormones primarily affect your kidney's ability to retain salt and water?
Yes.
And this is just an overview about all the different factors that could compensate for like hemorrhaging or bleeding out here, having low blood pressure, low blood volume here, decreasing blood pressure, again, low blood pressure. You've got short-term and long-term mechanisms. Now before going into that, short-term versus long-term, all right? Which of those is primarily going to rely on neural mechanisms, the short-term and the long-term?
Short-term.
Short-term. Long-term is going to be controlled by what?
Endocrine.
Endocrine. And what horrible system is the primary one that's going to be the long-term one? What horrible? The renin-angiotensin system. That's the big thing. And that's what they talk about, the renin-angiotensin system is the big thing that's affecting that. EPO, again, primarily is just there. The big thing I want you to know about EPO is its effect on red blood cell production. But again, anytime I'm packing more red blood cells in, pressure's going to go up. All right. This is just showing again what's happening with anything special here I want to mention here. I will mention this real quickly. We have said that for most of your body's tissues, when you increasing sympathetic stimulation makes blood vessels do what? Everybody? Constrict. Increasing sympathetic makes blood vessels do what? Constrict. If you are running from the monster, are there some tissues, some organs that might benefit from increasing blood flow? To help you, I don't know, get away from the monster.
Yeah.
Heart might want more blood. Mm-hmm. Don't even have to worry about the lungs. We'll see why you don't have to worry about the lungs. But the heart? Anything else?
Muscles.
Maybe your skeletal muscles? Maybe your brain, because you might need to sort of problem solve to find out how can I get away from this monster here? Is there a cave I can get to, or is there a superhero that I can call on? Those kind of important things require some brain function. So even though sympathetic stimulation for most tissues causes blood vessels to what? Constrict. The ones that need it most for emergencies do the opposite. They're going to dilate. So sympathetic stimulation of the ones to the heart would make them do what? Dilate. To the cerebral arteries, dilate. To the ones in your muscles, they dilate. So when you're in that fight or flight mode, sympathetic stimulation is causing blood vessels to do what? Constrict. Except for those to do what? Dilate. And notice what this allows. This allows your body to redistribute blood flow away from areas that don't need it to get away from the monster, and make it more available to the areas that do need it. So that's why you're running, your skin's gonna look very pale, because I don't need all that blood flow there. Do I need to be sending blood flow to my digestive organs at this time?
No.
Can't I digest food when I get to safety?
Right.
So all of that, all right, we're gonna cause those blood vessels to the digestive organs to do what? Constrict, so I'm not wasting cardiac output, but there's gonna be an increase in blood flow to the brain, heart, skeletal muscles. And that's going to be it for today because it's 2:30. Oh my goodness, where does the time fly? Wow, isn't it? We could just go another 3 or 4 hours, right? Because you're like, yeah, all right.